Good afternoon, everyone, and a very warm welcome to you on behalf of the WITS team in the Department of Family Medicine and Primary Care, along with Health System Sciences and the Adler Museum of Medicine. Welcome to this critical engagement webinar series in which we discuss, debate, and evaluate the ever-changing body of knowledge emerging as a consequence of the current COVID-19 pandemic. This series probes pandemic innovations, responses, and partnerships. And this weekly series is inspired by the image, characteristics, and survival story of the Cape pangolin, and so it is named after the pangolin. We seek to unpack the interconnectedness of health, humanities, environment, and science through a lens of systems thinking in these unprecedented times. I am the host of this webinar. My name is Nabila Bema. I'm the academic coordinator of the Bachelor of Health Sciences or BHSC degree program at the university and a registered research psychologist. In coordinating academic matters pertaining to the BHSC, I've had the opportunity and privilege to work with colleagues on the health system sciences track within the program. In today's live discussion titled Pandemics in Society, Community Engagements, we are very pleased to have two experts with us, Dr. Imtiaz Suleiman and Mr. Vinayak Bhardwaj. Dr. Imtiaz Suleiman is the founder of the Gift of the Givers Foundation, the largest disaster response non-governmental organization of African origin on the African continent. Heeding a message from his spiritual leader in Turkey in 1992, Dr. Suleiman left a flourishing career as a medical doctor and established the foundation at the age of 30. In the intervening years, he has traveled some of the most desolate, war-torn, and disaster-struck areas of the world, heading relief missions. He and his team have responded to the needs of countless of people affected by a wide range of natural and man-made disasters. Dr. Suleiman's passion for humanitarianism is fueled by the solid belief in the common humanity that unites us. Our second speaker, Mr. Vinayak Bhardwaj, is the current Regional Migration Advisor for Southern Africa for Doctors Without Borders, or MSF, having worked as Deputy Head of Mission for MSF South Africa for the last 2 years. Mr. Bhardwaj was born and raised in Zimbabwe and completed his university education in biochemistry and chemical engineering in South Africa. He is currently pursuing his master's in public health at the Johns Hopkins Bloomberg School of Public Health. He has worked in numerous fields, including investigative journalism, textbook writing, and international donor organizations. He has also co-founded a digital health company aimed at improving self-management of diabetes. Fundamentally, he is motivated by the quest for social justice through the prism of more equitable for all. We are very pleased to have these two speakers and a very warm welcome to them both. Just some logistics for today. I would like to now...
Sorry, it seemed that we had a slight internet interruption there. Nabila, back to you again.
Can you hear me fine now, Catherine?
Yes, we can.
Great. Sorry about that. I would like to now hand over to Dr. Suleiman. Dr. Suleiman, thank you. Over to you.
Thanks, Nabila. Thanks, Pangolin Society. Thanks, WITS and Family Medicine and all the different divisions involved in this webinar. Greetings to Vinayak, also my friend from Eminem. My brief for this next 10 minutes, I'm going to speak to those in this program about Gift of the Gifts intervention in COVID-19. That intervention was in different categories. 1 was medical, 2 was food, 3 was water, and 4 was fodder. And associated with that was stimulating job creation and going directly to communities, finding people, especially in the rural areas, to benefit them, but I'll speak about it as we go along. It all started around the 11th of March, when I was in Cape Town and I met Patrick Schofield from Becker Buddy. Becker Buddy was keen to support us if we launched something to intervene in COVID-19. And I made it very, very clear at the beginning that we can't rush to do anything. First of all, we don't know how intense the virus will be in South Africa. We don't know where the epicenter will be. People call me to set up field hospitals, and I said it makes no sense to me to put up field hospitals when you don't know where the epicenter of the virus is going to be. Also, when they call about field hospitals, I said I'm not keen to set up field hospitals outside an existing medical facility. It doesn't make sense either, and I'll explain that as we go along. And at the outset, we said, what would be the first need the criteria to intervene, or the most decisive intervention. You could have thousands of infected people, but if your medical profession collapses, there's nobody to treat those infected people. So priority is the medical profession, and that doesn't mean doctors. It means everybody associated in a medical setting, whether it's the cook, the nurse, the doctor, anybody else, the clerk, because anyone in that facility could infect somebody else and affect their families, and many medical personnel could die, as has happened already. So the primary aim there would be for personal protection for the medical personnel. And immediately, just after the 11th, we already started looking at importing, making arrangements to bring the PPEs in. The second preparation was, which of course we couldn't do, but we announced it and mentioned it to many government people, that outside COVID-19, there's already medical personnel that are overworked, they are stressed out, they're understaffed, and these are in normal situations, normal in inverted commas, in emergency, in trauma, in cardiac cases, diabetics, comas, or epilepsy, dealing with those kind of cases. But they're already exhausted with too many calls and too little rest. Now you bring in COVID-19. The difference between this and other conditions is that it affects the mental health of the medical practitioner or the medical personnel, because they themselves are scared to contract this disease. And we know the amount of anxiety COVID-19 has caused in the country and in the world. So you needed backup staff, unfortunately, which hasn't happened in terms of nursing, doctors in the critical areas throughout the country. That was the second thing that we had called for. On the 15th, the president made his first speech on a Sunday and said it's now time to declare this a national disaster, because the first case arrived in South Africa, in Hilton, which is not far from me. I live in Pietermaritzburg. And that same case was taken to Grace Hospital, which is only about 8 minutes from where I live. And of course, from that, the country was starting to prepare for the eventuality of the virus starting to increase. On the 16th, we started getting involved with private labs to set up testing stations throughout the country, because we knew if that happens, the existing services will not manage for testing. And the other issue about the testing in the private sector was too expensive. It was 1,450 rand per patient. And of course, working through labs, speaking to people, courier companies, we managed to bring that price down for the private sector to 750 rand to take the pressure off the government hospitals. So people should go to the private sector, because at that fee of 1,450, the public is going to say, okay, I only got a flu. I'm not so sick. Why should I go and test myself for COVID-19? I'm not feeling so ill. I'll get better. The problem with that is you're a walking time bomb. And to prevent a walking time bomb for those who are not ill, we encourage them to go for testing at 750 rand, and eventually getting most of what we managed to bring that down to 650, and all the other big labs followed. The prices dropped to 850. So that was the next stage. We then set up testing centers throughout the country, and we had mobile centers that could move to bulk testing in different parts of the country, which we did. Soon after that, we said, okay, what challenges are we going to have in the hospital? And of course, most of the frontline hospitals said, if infected patients come into the reception area, those who are not COVID positive can get ill, and this virus can spread throughout the hospital. So they wanted tents. We set up 37 tents for triage in various hospitals in the country at a cost of 3 million rand a month. This was in addition already to the PEPs that we were purchasing, procuring, and for the testing that we were doing nationwide. Then, of course, the doctors in emergency settings said, you know what, we need video laryngoscopes. There was only 15 available in the country at that stage, and we bought all 15 and distributed again to main centers throughout the country. And as we were monitoring what was going on inside in the rest of the world, we found, okay, besides the PPEs, a simple thing like non-contact thermometers was critical. And what gave us a big shock is when our teams went across, we've had 200 health facilities in South Africa with masks, both 3-ply surgical, KN95s, coveralls, gloves, head covers, shoe covers, sanitizer, and to that we added pulse oximeters and non-contact thermometers. But what shocked us is when our teams went to hospitals, and when they just presented the thermometers, nurses, doctors, CEOs broke out into sing and dance. And we couldn't understand why such a simple thing could create so much of reaction. It was obvious. There was huge anxiety, and nobody was receiving items. even though we've heard of the PPE scandal, we've been to many hospitals, and each one tells us the same thing. We've been waiting for months. Items haven't arrived. Nurses are going to go on strike. Doctors are not going to work because we don't have the PPEs here. We are at risk. And that has happened throughout from March till now, up till now, we hear the same story in many, many hospitals. So if so much of money was given for PPEs, then where is the PPEs? Why were they not delivered? Or were they purchased and not delivered? What happened? That's an important question that the government has to answer. In any case, we started doing that. And then we found, as an additional point, most of the hospitals didn't have reusable surgical gowns and didn't have scrubs. So that became another big issue, and we started supplying that. And then, of course, the simple thing of a pulse oximeter. Many hospitals didn't have that, and we bought them in the thousands and distributed pulse oximeters. We were preparing for ventilators. Everybody was preparing for ventilators. And the international trends and local trends showed that the ventilators were not as effective as high-flow oxygen machines. So we purchased high-flow oxygen machines and distributed them again to various hospitals, and we're still doing that now in preparation if the second wave comes. Then we said, okay, now let's get to the case of the field hospitals. And we spoke to Mitchell's Plain Hospital in Cape Town and said, look, we're not interested in putting tents outside the hospital, because tomorrow when you destroy that, all the money invested is gone. And you reduce staff in the existing hospital and create more anxiety already when there's a shortage of staff. So do you have something at the hospital itself which we can support? Because at that point, Tygerberg, Eiderfell, Mitchell's Plain, Kailicha were all in the same line where the virus numbers were rising. And I said, if you put a tent here in June, July, it's going to be crazy. Cape Town's got wind, rain, and cold all at the same time in winter. It'll be crazy to put patients in a tent outside. It's not going to make any sense. So they said, look, we've got a building here that we haven't used for many months, or many years. And to the credit of the health department in Cape Town, in 4 days, we got 5 signatures. We took that ward, spent 10 million rand on it, and converted it into almost like a private hospital capacity in 30 days. It's a 10 million rand facility. It's now visible for all to see in Mitchell's Plain. And today it's already got 30 COVID patients and more coming in. But again, there's a problem of staff in that facility. In health facilities throughout the country. And then we looked at the Eastern Cape. We were looking at cases throughout the country, and we found that the Eastern Cape had the biggest number of challenges in terms of support, supplies, hospital functioning, management. And we started focusing in a big way on Eastern Cape. And within 3 days, we covered 35 hospitals with all the things that I mentioned. And then we took Bishop Hospital, same thing. We asked, have you got a building? And they said, yes. This time, of course, the Public Works renovated the building, and we've supplied 120 beds, mattresses, 240 pillows. We're doing the curtains, we're doing the tent in the hospital, oxygen machines, pulse oximeter, non-contact thermometers, and bring other items, and it's already functional right now. The first cases from Fort Hare and other universities and cases from King Williamstown and around Bishu have already come into the hospital. That's the medical aspect of it, and we're still busy with that. In addition to that, we knew that after 27th March, after the lockdown, people are going to be hungry. We've delivered 300,000 food parcels to very, very hungry people throughout this country and supported 100 feeding centers. In Eastern Cape, we were surprised, we were shocked to find people eating plants, cats, dogs, tortoises, lizards, and frogs to survive. And they would go for days without food. In any case, there was no food to eat. Water was another big issue inside in the Eastern Cape. And we've put in the last 2 years in various areas, we put 400 boreholes. All have been functional. We had water tankers working in the Eastern Cape 7 days a week, to almost 12 to 14 hours a day, and it's not enough. It has been a real challenge. But right now, we're making another huge intervention for boreholes in the Eastern Cape starting on Monday. We're on site already. We're bringing in 3 drilling rigs to do more water in the Eastern Cape next week and to expand that services. People have no water for sanitation, no water to drink, no water for medication, and a whole lot of challenges. And the last point is fodder. Drought has been in the Eastern Cape long before COVID-19. And the major carnage with COVID-19 has been unemployment, the job losses, the hunger. And we said if we support farmers with fodder, which we've been doing since 2017, the fodder could help save animals, save income, save jobs, and reduce the amount of job losses. And we've been doing that in a large scale. We've also supported a manufacturing plant in Sutherland where pellets are made from fodder, high quality, nutritious pellets, which a smaller quantity can help a larger number of animals. And we've been doing that. And in the process, the situation is bad when the farmer tells you, I need a food parcel for my farm worker, and I need a food parcel for me and my family. And that is a critical case. And the last point is in terms of supporting jobs, we supported the farmers so they could keep the farm workers at work. And of course, when it came to the local, for the surgical gowns and the scrubs, we supported local companies so they could keep their staff busy. And finally, with the labs we supported, we're going to put off the staff wholesale. And by us supporting the labs, they not only kept their staff, but also increased the intake and employed more people to do the testing. I think my time is up and we can handle more things during the question and answer time. Thank you.
Thank you for that, Dr. Suleiman, and for sharing those insights around the really very on-the-ground challenges, both at the health systems level in terms of healthcare facilities, etc., but also on the very real lived day-to-day realities of people who have faced the challenges associated with COVID-19. Thank you very much for your presentation. I will now hand over to Mr. Vinayak Bhardwaj so that he can take over and present on his experiences. Thank you, Mr. Bhardwaj. Mr. Bhardwaj, please go ahead. Do we still have him on? Apologies, colleagues, if we can just maybe wait a few minutes while we just get Mr. Bhardwaj back.
Hi, good afternoon. I think I'm back.
Yes, thank you. We can hear you great.
My apologies. Just wanted to thank Dr. Suleiman for an excellent presentation and really just for the dedication and sort of principled support of Gift of the Givers at such a trying time, and also for that sobering reminder of the kind of non-COVID consequences that we are now living through. I will just quickly share my screen and I hope that we don't cut out again. Is that coming clear, Nabila?
Yes, we can see it great. Thanks.
Thanks so much, Nabi. So good afternoon, everyone. My name is Vinayak Bhardwaj. I'm from MSF, Doctors Without Borders. And I'm going to be speaking about community engagement during COVID, a topic that's very close to the hearts of a lot of MSF colleagues, and one that in particular we try to make a sort of principled component of our interventions. I think that to sort of kick us off or to kind of orient our thinking, we've often relied on the community engagement efforts by our colleagues in previous pandemics. As you know, MSF is a medical humanitarian organization that tries to intervene in genocides, pandemics, wars, and during natural disasters. And we try to do so with independence, impartiality, and neutrality. So we don't take funding from foreign governments, for example, and we try to address the needs as we see them. But critical to seeing them is actually engaging with communities. And more recently, this photograph shows our engagement with communities in DRC, where we were involved in the Ebola response. And there, Dr. Nguyen,
Okay, we seem to have lost Mr. Bhardwaj there for a second. If you would just kindly just give us 5 minutes until we can get him back. Apologies, everyone.
Maybe, Nabila, we could take some of the questions coming in so long for Dr. Suleiman.
Well, let's proceed with that. So, Dr. Suleiman, we had, I think, two questions directed directly to you. The first is from Anya Badiaka. Anya asks, to Imtiaz, how did your organization decide which hospitals or clinics would receive which supplies and how much?
Well, we got the calls from the hospitals themselves and the clinics. And it was just, we looked at the size of the hospital and we looked at the size of the clinics. We said, okay, this one's get 2,000, that one's get 500. It was also based on the amount of stock that we had. We didn't have like hundreds of millions of items. Remember at the beginning, they were coming in drips and drabs because of the situation coming from China, and of course with the borders issues and the airport issues. So they came in stages. So from what we had, we apportioned proportionate stock to different facilities. We first looked, we were following where the epicenter of the virus was, which hospitals were most affected, which areas around those hospitals most affected, and we went for those places first. And of course, initially there was nothing in the Northern Cape, there was nothing much in Limpopo, there was nothing much in parts of Mpumalanga and Northwest. It was predominantly in Gauteng, then went to the Western Cape, and then went to the Eastern Cape. So those are the three regions we followed closely. And then in between, we got a call from some of the other centers, we sent them. But even the centers themselves, we didn't have much calls from the other regions as much as what we got from Western Cape, Gauteng, and Eastern Cape.
Thank you for that response, Dr. Suleiman. I see that Vinayak is back, so we'll pause the questions for now, and then we'll hand over to Vinayak.
Great, thanks, colleagues. Sorry, please bear with me. I'm at the Durban airport, and it seems the connection is not what it should be. So I will just jump straight into the second slide of my presentation, which thanks Nabila for sharing. And it was just to explain that community engagement has been critical throughout our efforts as a medical humanitarian organization. And this particular photograph shows efforts in the DR Congo during the Ebola pandemic, where we tried to provide a response. In the next slide, I include a quote from Dr. Nguyen, who is a prominent doctor leading our efforts in DR Congo, which I think has relevance to what we're discussing today around community engagement. He describes how I saw the impact that these relationships had on trust during the 2014-2015 Ebola pandemic in Guinea. Although he also refers to, later in the article, to Congo as well. Many attempts to engage with affected communities during Ebola epidemics have been tone deaf. Little effort has been made to understand the public's concerns or to find out what they understand from the messages being conveyed to them. Recognizing the need to listen to the community and be prepared to answer hard questions truthfully, we shifted from a health promotion strategy of delivering rote messages about viral transmission from bats or the importance of hand washing toward genuine community engagement. We recruited trusted community members and trained them in active listening and communication techniques, discussing how to address questions they would receive from the public. The questions the public asked us reflected their sense of anger and betrayal at Ebola profiteers, and their worries that the focus on Ebola would be short-term and would not address more common and equally deadly everyday health issues. We found that acknowledging and addressing issues of poverty and injustice and using examples drawn from questioners' experience went a long way towards allaying the concerns underlying these questions. And so with that sort of background principle, I think we tried to design a lot of our operations in South Africa, especially in response to COVID, bearing these sentiments in mind. So just briefly, in South Africa, we operate in 4 main sites, and Joburg was added as a 5th site during COVID. And very briefly, in Rustenburg, we provide care to victims of sexual and gender-based violence. In Tshwane, we provide care to migrant populations in the most part, as well as inner city communities. In Eshowe, where I've just been based, we provide TB care in rural communities. And in Khayelitsha, we try to pioneer new models of HIV and TB care. All of our operations during COVID were repurposed not only to respond to the very real pandemic-related needs, but also to the kind of society and community in which each of these projects was based. And that care tried to address the entire cascade of the disease, from prevention efforts, from efforts to link people to care, as well as the care itself, and then sort of, I guess, what clinicians call, I'm not a clinician, but what clinicians I believe call continuum of care. So sort of post-discharge of patients from facilities, and trying to ensure that they were adequately protected when they were no longer in facilities. And so I'll try to describe some of these efforts and how important it was for us to engage with communities in order for the success of any of these interventions. Next slide, please. Here we can see that in our health promotion efforts, we went sort of door to door across communities, trying to spread the word, but also trying to really gain the trust of communities in order to roll out some of our interventions. And one of the things my colleagues did, and we can maybe see it described on the next slide, is this idea of training of trainers. So we identified leaders in community as well as community activists who we then trained in health promotion around COVID, be it sanitation issues, be it issues of sort of adequate protection for those who had comorbidities or who were elderly, trying to ensure they were adequately shielded. These workshops and these training of trainers alongside the medical interventions that my colleagues were responsible for. Next slide, please. And more importantly, I don't think we'll get a chance to see these videos in this presentation, partly due to time constraints and also due to the internet connection. But the two videos I've linked to there show some of our efforts at tackling stigma, because I think an important consequence of failing to engage communities is a stigmatization of those who end up ill. In that picture there, we see an unfortunate consequence of, I think, community disengagement, where parts of the Catherine Booth Hospital here in KwaZulu-Natal were burnt down by community members overnight when it was decided, without any consultation or engagement, to move the sub-district's COVID patients to this particular hospital ward. And this is not to blame anyone, it's to say that as a collective, we were so focused on trying to provide care and to ensure that those who were critically ill were sufficiently isolated, that we forgot that there are community members whose real concerns and fears had not been addressed. And sometimes that process is as critical as trying to care for patients in need. And so the two videos would show two separate initiatives to challenge stigma. One in Eshowe, where with the partnership of a local mosque, we were spreading messages using their PA system, trying to address concerns that members of the community had. And the second video shows the experience of a patient who was thrown out of her house in Khayelitsha due to stigmatization when she was diagnosed with COVID, and how she went about sort of addressing that. But I'll leave you to watch that, and hopefully the slides can be shared, so that's possible. And here, back in Eshowe, which is a rural area, we often engage through our HIV program with traditional leaders and traditional healers as a way to tackling some of the concerns patients have, because often they're the first port of call for people who are ill. And as he says, there were so many rumors when this thing started because people saw death on the TV. When they were told they would be testing, there were those older ones who thought that the government was coming to Jova, inject them with the disease, and they went to hide. In this place, people trust and listen to traditional leaders, and when they're sick, many of our first people, whenever people first turn to a traditional healer, Beiki Sashandu, a traditional healer here in Bongolwane, shares, and he's been working, and he continues to work at the moment in ensuring safe burial practices, hygienic animal slaughter, and he's spreading the message around the importance of getting tested for COVID in the event that they screen positive, and he has been trained in some basic sort of screening techniques, and sort of is at the forefront of our community response here in Eshowe. Next slide, please. And here it's just a slide showing one of our partner NGOs, Shine, that's been responsible for community engagement throughout our HIV response, and they were critical in terms of screening and testing efforts for COVID during the pandemic. Next slide, please. One of the important consequences of this kind of community-led efforts and trying to really sincerely integrate them into our response has been that they are often very useful in helping to identify potential hotspots of the pandemic. So here is just a site from one of the coldest nights in Joburg, where our team was set up doing screening and testing at a shelter. This was during level 3 lockdown, when people were now allowed to work and so on. Where we found out that the best time to really target our interventions would be during the evening when the men had come back from work. And so you see the sort of setup that they had organized. Next slide, please. And then, having gone through the prevention efforts, linking people to care through screening and testing, the care itself we tried to provide through the construction of a field hospital in Khayelitsha was really a product not only of medical innovation, expertise, and agility, but also a result of community engagement. And MSF has been in Khayelitsha for the last 20 years, so some of that engagement is long-standing. We partnered with one of the community health forums, which 2 years ago MSF itself had helped establish, and we went on a sort of door-to-door effort together with the province health authorities to try and ensure that when this hospital was constructed, it would be with the participation of the community. I can't say that it was a complete success, or even defining what complete success of community engagement is difficult. But I understand from my colleagues that it was incredibly important to ensuring that patients were referred early, that when they were discharged, there was adequate care provided for them. And so I know my time is almost up, but maybe there's the last slide if we could just quickly go to. So I think for us as MSF at the moment, we're really grappling with some of the points Dr. Suleiman so powerfully raised at the end of his presentation, which is the significant non-COVID consequences of TB. We know that case finding has dropped 30%, testing has dropped 50%, unemployment in this country has risen, 2 million people have lost their jobs, which comes with it all sorts of social ills. In South Africa, we also worry about things like xenophobia, communal violence, that sort of thing, and hunger, as Dr. Suleiman pointed out. And the urgency of the need for a community response that is not facility-based alone is important. And of course, in addition to all of this, COVID remains a major concern. Just today, I see a news article from the Daily Dispatch that PE's hospitals are almost full, as they seem to detect what might be a second wave of the COVID pandemic. And so I think the lessons that we seem to have learned through our engagement with communities, that we act early, often, and with openness and transparency, and to try and ensure that we expend as much effort and time and sincerity and a kind of connection to communities in our prevention efforts, given the lack of medical resources when things reach the stage of the hospital. So I think this is a very timely conversation, and I'm very grateful to colleagues at WITS for organizing it and for inviting us to join it. Thank you so much, and I apologize again for the connection issues.
Thank you very much for that presentation, Mr. Barwash, and for highlighting the non-COVID or non-directly impact-related COVID factors that impact on communities, and the need for contextually appropriate interventions and the need for community engagement to facilitate that. So how we will proceed now is we'll take some questions based on what's been posted in the chat. So please, if you haven't asked a question yet and you'd like to, please feel free to do so, and we'll facilitate the discussion from there. So the first question we have is from Mwa Mpaso. Good day to all. How has the pandemic affected the education sector, especially early learning education, as this is the driving force for future development and economic sustainability? What measures are in place to mitigate this? So I don't know if Dr. Suleiman or Mr. Barwash, if you've interacted with the the education sector and the impact of COVID in relation to this. Thank you. So perhaps Dr. Suleiman, would you like to go first?
Sorry. Just repeat that question.
So the question is, how has the pandemic affected the education sector, especially early learning education, as this is the driving force for future development and economic sustainability? What measures are in place to mitigate this?
Well, that's the education one has been a major crisis. First of all, the feeding stopped at all the schools. So you had hundreds of thousands of children who were hungry, because when they shut down the schools, the feeding also shut down. And you had a large number of hungry children who couldn't do anything. Of course, they couldn't study because the schools were closed. And you would find a lot of them in areas that we've been going to dump sites, trying to raise food. We saw children eating from, jam tins, from peanut butter bottles, because they were very hungry. And the mothers and family members would say, because the school education program, feeding program is shut, these children have nothing to eat. The second problem was that a lot of kids, a lot of the more affluent schools could continue because they had online facilities. And this became a very unequal system, because many kids who were online could carry on studying, and those kids who were not online, who did not have data, who did not have the means, could not study. So these kids, were set without tuition and guidance. Thirdly, those schools, again, that were better resourced could, of course, they already had lower number of children in the classes. So it wasn't so much an issue of physical distance. I don't like the word social distancing, physical distancing in the classes, because they already got small classes. The other schools that tried to do that didn't have the means because their numbers were too big already. And it meant they had to cut down on teaching time and send kids to school, twice a week, or 3 times a week from a certain amount of kids. And the following week, the other half kids come 3 times a week. So you lost out a lot of education time because you could not catch up with online learning. Then the schools had 2 more challenges. One was lots of schools don't have water, especially in the Eastern Cape. So again, about community engagement, the communities were telling us in the different rural areas that we've been to. The government tells us that we need to wash our hands. We need to sanitize. And from where are we supposed to get this water to wash our hands? Our children go to school. There's no water to wash their hands with. The toilets are not functional. They put toilets. So many children at high risk of falling into the pit, and many children did die from that and have been still dying from the pit toilets. So from the educational point of view, these were all the challenges: food challenges, water challenges, learning challenges, and then the teachers. The teachers were scared to come to school because they themselves felt they had high risk, and especially the older teachers. So we had found that a large number of teachers did not want to come to school because they were scared. And then the parents of the children at school were scared that if the children come from school with a disease home, and especially for the elderly and those who have comorbidities, especially in the rural areas, what happens to them? So in essence, a large amount of teaching time has been lost because of fear of the illness, fear of contracting the illness, no food, no water, no teaching time at the more poorer schools, not so much so at the highest, the more affluent schools. They went on well. We've seen the affluent schools, most of them have been functioning very, very well. In some cases, they were ahead of the syllabus. Some of them during lockdown had already started work in June. They were given special concession to do that. And of course, you admire those teachers and those children who want to learn, and everybody wants to learn. But 2020 will probably go down as the most unequal year in education in this country.
Thank you for that, Dr. Suleiman. Since we have you on the line at the moment, we have a question from Janet Giri, who's directly addressed a question to you. The work of your organization has been commendable and very appropriate. You have provided both expertise and resources and equipment. Have there been any funding challenges at this time when there's so much pressure or competition for funding and resources?
We're very fortunate. We were not born, 3 or 4 months ago. We're in the country for 28 years. And we have a track record inside and externally. And strangely enough, our biggest support in our history has come during COVID-19. We don't, as a rule, we don't make proposals. We don't go to government. We don't go to corporates. We don't go to the public asking for money. We announce what we do, and that we get enough media coverage. We don't have to do paid advertising. And because it's not something new, people know us, not only from corporates or from government or from affluent people or from educated people or those with degrees. And we go to the rural areas. We've been virtually every corner of this country People wait for us. They know our brand. The moment they see our truck coming from the hill, they start screaming and running into the streets because they know something is coming. It's a sign of hope. So because of that kind of feedback, a lot of people in the rural areas have family members who are working in top-class companies. From the Eastern Cape, they'll be working in Johannesburg or in Cape Town from the Eastern Cape, and similarly from other parts of the country. And we would get a message from somebody in some corporate company to say, you delivered a wheelchair to my grandmother, or you gave a food parcel to my uncle's some relative. And as a result of that, you would find that people in the CSI started pushing more and more towards us. Companies that never gave us funding before. Let's take, for example, Anglo-American. In the first tranche gave us 19 million as one hit. Then came Implants, gave us 12.4 million, and now have given us more money for the Eastern Cape. And then strange things started happening. We started getting calls from Europe and America. People we don't know how they've been tracking us. And suddenly we got like Walmart, Microsoft, Ford Foundation, and other companies starting want to invest with us to help us. So in terms of funding, no, we haven't had a problem. And even if you give us more funding, it's most welcome. But there's only so much you can do in a day. It's easy to deliver 3,000 food parcels in 3 hours in one spot. But to deliver 1,000 food parcels or 50, 100, 70, 90, 20 in 30 different spots takes a very, very long time. Because again, of the challenges of lockdown, social physical distancing, old people, getting them to go home. One day in a place called Nonzamo in Strand, it took us almost 10 hours to deliver 1,250 food parcels because there were just too many old people there. And eventually, the curfew started at 8 o'clock, and we broke the curfew. I told the police, there's no way we're going to stop distributing here because these people are hungry. They need to take the food home. And the police said, we agree with you. And they brought in more police staff to help us take the old people home. So yes, there have been challenges in that way. But in terms of funding, I must say thank you to South Africa. The support has been enormous during this COVID-19.
Thank you for that, Dr. Suleiman. We also have a comment from Jennifer Watermeyer. Thank you, Dr. Suleiman, for the amazing work you've been doing during this pandemic. Similar to the question above from Anya, given the massive needs and demands in so many communities across the country, how did you decide where to start rendering assistance and distributing resources to address these needs? What kind of triage system did you use?
Again, because we're in a country, and we have teams, we can respond to 9 provinces at the same time. This is something it's not difficult for us. This is in our blood. So we could run if you just go to our social media pages, you will see how many things we do in one day. Because again, we have our ear on the ground, we have contact with traditional leaders, community leaders, activists. We be on site, our teams move around, we place throughout the country. For us, it's not an issue. And we would get, and what would help, for example, and again, there's a lot of spiritual thing in what we do. And we would get the same message from the same area like 15 times. When I say it's not 15 times, I don't mean from the same person. Somebody would say, you know what, we are from a place called Pedi, we got no food. And then a few hours later, we'll get that message. And again, so you start getting a host of messages from the same area and realize, okay, there's a problem. We send somebody to investigate and realize the problem is bigger than we thought. And the other thing that happens, every time in the media, we know we're going to get flooded with calls from different areas. And then we hone in to say, okay, this area gave us 20 calls, this area gave us 2 calls, this area gave us 1 call. Let's check with the activists in the area what is required where. And you would find, okay, most areas do need help, but there are priority areas. For example, they haven't had water for 4 years in one area, or 5 years, or 6 years. In an area of 1,000 families, only 10 food parcels have been distributed. So we use that system again to highlight, who needs help fastest, and of course, where the job losses have been the most major, and where unemployment before COVID-19 has been the most biggest. And so we target those areas, and we can't cover every area, it's impossible. But we try to do priority areas as best we can.
Thank you for that response. The next question is also from Paso. I think this is more directed to Mr. Parwaj. What were the main primary healthcare strategies that were taken to engage communities and promote health-seeking behavior in fighting the pandemic? As we all appreciate, this would be the first line and cheaper option in dealing with the problem. Mr. Parwaj, would you like to respond?
Sure. So it depended on the context, but typically where we already had projects existing, it wasn't very difficult for us to sort of repurpose our efforts towards primary healthcare approach, because we were already in the DOH facilities doing something of the sort. In Johannesburg in particular, we set up at shelters in particular, because that's where a lot of people who were homeless or had nowhere to sort of shelter in place during the lockdowns were sent to. And there we set up small interventions where we would have 3 gazebos or so on. It was winter in Johannesburg, so there wasn't that much rain or anything of that sort. So we were able to set up in the grounds of most shelters. And please, could you point me to the other half of the question? I think that was the question around primary healthcare and how we organized our efforts there.
Sure. So the question was, what were the main primary healthcare strategies that were taken to engage communities and then promote health-seeking behavior in fighting the pandemic? As we all appreciate, this would be the first line and cheaper option.
Yeah, so as I tried to elaborate, we spent quite a lot of effort on this training of trainers approach to health promotion. So our health promotion team was of just 3 or 4 individuals, and they identified communities where leaders would make themselves available for this training. We would train them in how to encourage members of their community to wash their hands. We distributed lots of cloth masks around the different project sites where we operate, but particularly in Joburg as well. And through that training of trainers, we kind of almost built an exponential and organic way of developing a community around that. So each community that experienced this training would inform another one, who would then sort of provide it to the next, and so on. And that's how we try to increase the footprint of that. And I know one of the questions also asked, I don't know if I can answer it because it's all related, is how receptive has government been to these community-based interventions? And the answer is very. So Department of Health works very closely with the Clinton Health Access Initiative, and they've asked us to develop the materials we use during the health promotion efforts so that they could be scaled up and made available throughout the country for any potential second wave. The last point I'll make on that is also that it's not sufficient. I mean, all of us have been bombarded with messages around health promotion. And one of the things our colleagues discovered is that often the advice of a trusted community member was given a lot more prominence than simply messages they were hearing all over the radio and TV and so on. So, and often that was useful, particularly when they had specific questions or myths that they needed to have addressed. I don't know if that also goes towards some of the other questions I saw around the health promotion response.
Yes, thank you for that. Thank you for that, Mr. Barwaj. I think the question you touched on was by Ketsia Lewins, who spoke about the contribution of state as well. So I don't know, Dr. Suleiman, I don't know if you have anything you would like to add to that. How well do you feel? How do you both feel that the state has responded to community needs? I think Mr. Barwaj just touched on that. I don't know if you'd like to add anything.
In terms of community needs, there's been it's all the things that we've been talking about in terms of water, school feeding systems, the needs for the hospital services itself, COVID testing. The government has been in a difficult situation because before the COVID itself, I mean, our economy was going downhill. The finances were in a crazy situation, and just too much came to bear during this time, and it was impossible for government to be in all areas at the same time and cover all areas at the same time. For example, the water crisis has been going on for almost 3 years and still hasn't been a solution to that. So communities, on the one hand, were demanding services in terms of support, and it is, to be honest, a lot of them told us that they're not worried about COVID-19. They're not worried, they'd rather die from COVID-19 than die from hunger, because hunger was something that superseded everything in this country. And when areas where they went to that had no water, they said for weeks we haven't had water, how are we going to survive? So hunger and water became the priority for that superseded COVID-19. And many people didn't seem to be afraid of COVID-19 because to them, It was another disease. They got TB, they had HIV, they had other type of illnesses. You know what? What's the big deal about COVID-19? And you would find we all expected the major crisis to happen with those patients with HIV and TB, and it didn't seem to have happened. So that wasn't a big challenge. It was the emphasis we went everywhere again is, why are we not getting food support? Why are we not getting water? And of course, at some point they mentioned, why are the hospitals not getting enough support? Why are there not enough staff in the hospital? And why are there not enough facilities? But to be honest, that wasn't the number one priority from poor communities, because of course we're working with poor communities.
Thank you for that response. So in relation to that, we do have a couple of other questions on the role of government. And so I'm just going to read out, I think it's a string of 3 different questions from 3 different audience members addressed to both Dr. Suleiman and Mr. Barwaj. So the first is from Victor de Andrade. Thank you. He thanks both organizations for their efforts. And the question is, what are your thoughts on governments potentially absolving themselves of responsibility because they know that organizations like yours are there to provide essential services? How do we balance the needs of people in situations of need and crisis, while also keeping governments accountable to people and fulfilling their responsibilities? So that's Victor Andrade. And then we have a similar question by, I think it was Jeanette Giddy, and I'm just going to quickly find that. Jeanette Giddy says, as was referred to, the PPE corruption issue has been very disturbing. Given that PPE procurement was a government responsibility, do you think this will undermine the NHI? And then the question by the anonymous audience member. Thank you for this powerful discussion. The question is, what both responses seem to show is government's failure to respond adequately to COVID-19 and the challenges of development in the democratic era. Do the speakers feel that the state has failed its citizens? So perhaps we can go with Dr. Suleiman, since you are, your mic and that is open, and then we can go to Mr. Barwaj.
Look, it's to be fair to government. You know, yes, they failed in certain areas, and in certain areas they've done well. They've tried to do the best they can. Remember, we're coming from a situation where our finances are not comparable to Europe or America. That's number one. And secondly, we're the most well-resourced countries with first-class health systems in Europe and in America. You can see the crisis in those countries. The death toll is far higher. The infection cases are far higher. The health systems are far better. They have better sources of water. They have better, more well-nourished people compared to South Africa. So in those situations, when those people had such kinds of difficulty, you know, what do we expect from South Africa? On the one side, yes, we have the challenge of resources, but we also have another crisis in terms of the one of the issues that I have was that we said we're doing lockdown to prepare the hospitals or prepare the health system to deal with the pandemic. And that truly was not done. Because if that was done, the first thing we should have done is bring in more medical personnel, bring in more staff, you know, nurses, and all we had to do was rotate them to the areas that had the biggest amount of cases. We could have brought them from other facilities to these areas to support existing hospitals, which was not done. And secondly, the outcry for PPEs, again, there should have been unlimited supply, unrestricted supply. And we couldn't say then there was no money, because I spoke to somebody very high up in government, and I can't give the name, but the person told me confidentially 15 billion went into this PPE deals with everybody. So if they had 15 billion, we could supply the whole continent with that amount of money for the PPEs. So the government has failed miserably, you know. Thirdly, a lot of them didn't know what the hell was going on, you know, in the hospitals. Some of them asked, is there really hunger in Eastern Cape? In the Eastern Cape, we brought everything to the fore. I mean, the media told us this is such a boring province to cover stories. There's no excitement here. But when we started exposing the water crisis, the hunger crisis, people eating plants, and those were not our words. These were people themselves saying it. And they come on the media and say, yes, my child ate plants. Yes, my family ate cats and dogs. Yes, we're eating tortoises because there's nothing to eat here. And we go to the hospitals, and again, the staff say we don't have the support. And you find on several interviews, I actually challenged the Premier and the MECs to go out to the rural areas, to get out of their offices, to get out of their nice houses and expensive cars and go rural. And go rural yourself. And I invite them again to go rural and ask the people who's come here. And they will tell you, nobody has been here. So they failed in terms of checking the areas out itself. Their advisors, their staff below them have failed in giving information across to them. In most cases, and we found that not only about COVID-19, in many situations, people, the staff tell the boss, what he likes to hear or she likes to hear, not the actual situation of what's going down on the ground. Immediately after we exposed the hunger situation, the next day in a place called Tilplat, and where we were, we found the next day after that media coverage, it was quite a hard-hitting media coverage on the response to government or response of government. Messages were gone out to all the health facilities in Eastern Cape to ask, is there really malnutrition in Eastern Cape? Is there really hunger? You have 4 months down the pandemic and you can't answer a question like that. There's something seriously wrong with the way you're doing your work.
Thank you for that, Dr. Suleiman. Mr. Barwash, I don't know if you have anything further you'd like to add to that question, because it was addressed to the both of you.
Yeah, thanks. Dr. Suleiman has covered some very important ground there. What I would add is just to support the point that government did play a critical role in the beginning of the pandemic, and the Department of Health in particular deserves tremendous credit, because as much as we, for example, as MSF, are concerned, we only dealt with a tiny fraction of the total caseload faced by South Africa when it came to COVID. The bulk of it was dealt with mostly in the public sector, and I imagine some in the private sector as well. And there's no doubt that the colleagues we work with in Bongolwane and Eshowe in rural KwaZulu-Natal, for example, or Khayelitsha and Rustenburg and Joburg, the colleagues from the Department of Health we worked with extreme dedication. At the senior level, we often had meetings with the Department of Health over weekends because they didn't have any capacity during the week. And during those weekends, they were very open and very frank about the kind of concerns they had about their strategy and the assistance they needed with that. So in many respects, government's response is to be lauded. Where I think the social consequences of the lockdown and so on remain unaddressed is what Dr. Suleiman has really outlined with great sort of precision. And during the lockdown for nearly 3 to 6 months, the Department of Social Development we operate is and so on. It was very difficult to the widespread that had been promised from our.
Sorry, Mr. Barwash, we've lost you there. Okay, while we wait for.
Hi, I'm back.
Okay, perfect. We can hear you.
I'm not sure on which note you lost me, but just to say that with our experience with DRTB patients and their ability to access disability grants, it's been really difficult. And it's even fair to say that many of them have been abandoned at this particular moment. So just to reinforce the point Dr. Suleiman made, the social relief that should have come together with the lockdowns and the public health strategies has been very slow and in some cases absent on the ground.
Thank you for that. So we have reached 2 o'clock. As we do have still a few more questions, we will stay online for a little bit longer. And so I'll just get right into it. There were some questions on migrants. So the first one is from Kudakwashi Chitofiri, who says, how accessible has been efforts to alleviate the effects of the lockdown to migrant communities, especially given that a majority of them are undocumented and have an illegal immigrant status? Are they comfortable to access help, whether private or public? And then Chioma Onukuku says, Mr. Barwaj, what informed your grouping the migrant and homeless communities together? So Mr. Barwaj, perhaps you'd like to take those questions?
Sure. So in terms of accessing help, if it was medical help, the clinics that we operated with in Joburg and Tshwane particularly were very receptive to providing care to undocumented migrants or migrants whose immigration status had lapsed during the lockdown. And that was entirely through the public sector. The other question was around Kudakwashe's question, I think it was.
Yes, so it was Chioma Onukuku who said, what informed your grouping the migrant and homeless communities together? That was...
Right. We didn't group them together. A lot of undocumented migrants happened to be placed together with homeless individuals in the shelters within inner city Joburg. And so provision of care to the shelters led us to realize that a large number of them were undocumented migrants who couldn't make it out of the country in time or who had nowhere else to go. And so that was how we came into contact with them. Many of them didn't have any other family in South Africa, and so ended up in the homeless shelters.
Thank you for that.
I just want to add some point in Nabila. Nabila, just to add to that, a lot of foreign nationals called us, and and it was heartbreaking. They said, "Look, we don't fit anywhere. We don't have documents. We don't fit in this country, and we can't go to our own countries. We know people are upset with us. Some of us do bad things in this country. We understand that, but all of us are not bad people." And they said, "Okay, forget us. Our 2-year-old child or 5-year-old child, what wrong have they done? They're hungry. What can you do to help them? Please, can you deliver a food parcel or some food, but just give it to my children. Me and my wife won't eat." It was that kind of sentiments and emotions that we received from foreign nationals. And we helped a lot of them. We helped a lot of foreign nationals from different countries, and they arranged their communities together, and we delivered food parcels, full food parcels, all of them. Because at the end of the day, during COVID-19, it's all about humanity. It doesn't matter whether you eat legal or illegal. The point is you are suffering. So all rules are bypassed when it comes to humans in crisis. And we covered and helped a lot of foreign nationals. And they were extremely grateful. We were not interested whether they were documented or not. Right now, it's a crisis. And we said, in terms of crisis, you do the best you can to help people. It doesn't matter what others think about them, whether they should be in this country, shouldn't be in this country. Right now, they are hungry. The children who are innocent, even they are innocent, the adults are innocent. We can't look the other way and just help, a South African society and ignore those who are in need. And then we made the point. We said over 30,000 South Africans were trapped outside the country during lockdown. And a lot of them ran out of resources. They had no money. They had difficulty in coming back for various reasons. And who helped those South Africans? Was it South Africans or was it foreigners? It was foreigners that took care of 30,000 South Africans outside the country. Why should we as South Africans not take care of those people in stress time and difficult times inside our country?
Thank you for adding to that discussion, Dr. Suleiman. Most valuable points there. I think we'll take 2 more questions before closing. And just a reminder to everyone that the session will be recorded and the slides will be made available on the website. The second to last question is from Wilson Bowalia in Zambia. My question goes to Mr. Barwaj. How is your organization addressing myths and misinformation surrounding COVID-19 and stigma suffered by COVID-19 survivors?
Thanks for that. In terms of the myths, I think some of the ongoing health promotion work has really emphasized not necessarily telling people what they believe is false, but often getting community members themselves who believed in one of those myths to then sort of share their own testimony of how they feel that they've changed their minds. And that's often much more convincing than somebody with a white coat from MSF saying what you believe is wrong and this is what's really correct. I would say that's been the sort of primary contribution in terms of challenging myths.
Okay, thank you for that. And then from Professor Cook, top tips to plan for a second wave. how is this done when predicting is so difficult in the face of significant uncertainty? And perhaps both Mr. Baroj and Dr. Suleiman, you can both take a stab at this question before we close.
There's no issue about any difference in the second phase and the first phase. It's still the same virus. And the same rules that apply in the first situation applies in the second situation. It's about people being responsible. Responsible, go out only if necessary. Wear your mask, cover your face and your mouth, and you see a lot of people don't do that. Again, sanitize all the time. And the most important thing, of course, knowing that if you're going touching services, going shopping, going in the malls, don't touch your face. Come home and wash your hands thoroughly, and then you can touch your face after that. It's no different in terms of individual accountability and responsibility to make sure, the points I mentioned, or being responsible and not going out is not necessary to go out. The second thing is what we didn't do the first time round. Support the hospitals. But the PPEs must be there up front, but I don't think there's any more left now, with all the scandals going on. And also make sure that additional staff, because a lot of medical personnel got burnt out, like in Europe and America. So we need to do that quite urgently. And thirdly, besides the medical facilities, we have to find a better system of supporting hunger, of people being hungry and providing water. But the virus itself, it is just a simple precautionary measure, because the second virus is absolutely no different from the first one.
Thank you, Dr. Suleiman. Mr. Baraj, your thoughts?
Not much more to add, and I certainly wouldn't want to dilute from the brilliance of the points Dr. Suleiman made, but just to say that I think we all accept that at this stage it's impossible to arrange another lockdown. The economic consequences and even the health consequences are far too significant. So the points Dr. Suleiman made about ensuring safe distancing and so on are absolutely critical. And again, to emphasize the theme of this particular meeting, engaging with communities where they're at, not where we want them to.
Thank you for that, Mr. Baraj. So I think we've really reached our limit for today's session already at almost 10 minutes past 2. I would just like to extend my thanks to both speakers. Thank you very much for such insightful presentations, for really bringing the lived realities and the challenges that people and communities have faced, and the importance of community engagement, and the need for this in terms of the consequences that COVID-19 has had. I think what we can take from this is that there really is a need for intersectoral and transdisciplinary collaboration and action. And we need to really facilitate effective community engagement in order to address the disparities and inequities that COVID-19 has made evident. So having said that, I would just like to remind everyone of next week's webinar, where we will be looking at issues of human resources and burnout. You can find the details on the slide, and also just a reminder that the presentation for this week, the recording as well as the slides, will be made available on the website that's depicted on the screen shown. So please do feel free to access that. Thank you everyone very much for attending, and thank you again once again to our speakers for their insights and for taking the time to share your experiences and insights with us. It's very much appreciated. Thank you.